So on the one hand, it's no shock at all. It's a completely unsurprising result. On the other hand, I still think it's quite important that that result is in print, that we kind of get to point to it, because, you know, traditionally, stroke has been specifically singled out as being somewhere where telemedicine makes sense. You know, it goes back to, well, I don't know, 15 or so years ago when Stroke Doc was being done, one of the first trials looking at how telemedicine can help stroke, you know, done through UC San Diego, Brett Myers. And that, you know, again, the result was common sense. It's helpful. It's not as good as me being at the bedside, but if I can't be at the bedside, you know, it helps me be a bit cleaner with my diagnosis over, say, just being on the phone with them, right? And so there's many aspects to that. You know, in part, it's been helpful with our experience with Telestroke. You know, it's not so much the magic of me being able to see patients via video, because it's challenging, and neurology is a very hands-on specialty. And so we always feel like we just wish we could really reach through the camera and just be there, you know. And it really depends on the quality of the bandwidth, and, you know, it depends especially on things like who's going to pay for it, right? Which up until very recently, traditionally has only been critical access in rural hospitals, which is fair enough, where they don't have the ability to have specialists at the bedside. But it's also where the resources are limited. You know, when we in Arizona, for example, had been doing Telestroke with some of the hospitals up in the mountains, you could tell what the weather was like by the quality of signal. You know, like, oh, it looks like we're getting pixelations. There's the wind blowing today. Yeah, pretty much. Okay, we'll do what we can. You know, so there's a lot of downside, but it's better than having no resources. The main concern we've always had, at least I've always had, is, you know, it's only been deployed for acute stroke. Right? It's been proven to be beneficial, but it's the acute stroke stuff. And so so traditionally we've rolled a camera up to the bedside in the emergency department, and the ED doc is kind of walked off, and the remote doc is then trying to figure it out with the patient. And then that's it. And so now the patient maybe gets admitted to the hospital or whatever else, or maybe the remote doc says, oh, it wasn't a stroke. I don't know what it was. Probably Bell's palsy, or, you know, who knows, get an MRI. But then they're done, right? And so you still have a remote patient, and now your choices are they get no follow-up, or there's nobody to kind of tie a bow on this and do the really important job of really working through all of the risk factors and doing some tests, and then following up on those tests and following up on those, and coming up with a final plan for what to do, and then arranging follow-up and making sure there's continuity. So that part, speaking personally, that's always driven me crazy. In our big banner system, for example, we have a lot, you know, I don't know how many, 30-something hospitals, and a number of them are managed remotely with Telestroke, and then eventually they'll dribble over to us, and so we see those cases, and what we'll often see is the Telestroke doc did the right thing, but then the patient was just left with the hospitalists, and none of the dots get connected. So in stroke, for a certified stroke center, we have a lot of metrics and a lot of requirements for, you know, what we have identified as being important quality things. And we don't see those getting done if we don't have somebody managing that. And so the importance of this abstract is that it shows us that we can do a heck of a lot better if we can try to connect those dots more than just that acute phase in the emergency department.